welcome to the Westin MCAT podcast with your host, Ahmed
and Eric Olson.
Welcome back, everyone, to another episode of the Westin MCAT podcast with Ahmed and Eric. Today, we'll be looking at the circulatory system, starting with the anatomy of the heart and then following the transport of blood through different organs and structures and how that contributes to whole body function. Before we dive into that, Eric, I know you were moving recently. Not a huge move, but a move nonetheless. You guys settled in now?
Yeah, I built a bookcase yesterday, so we're still doing stuff. It's certainly not all finished up yet.
Was it an IKEA bookcase?
It was I think it was a Wayfair book. I don't know. I didn't purchase it myself. I just received it from my wife and then got to work. So
there you go. Yeah.
We're still doing some of that, and we got some boxes to unpack. It's such a process, and I was talking with some of my co-residents about it, and I think, not to make excuses, but when you have kids, that takes up so much time, and you can't be doing other things. And then you also have a lot more stuff, because I was talking with my cohort, and they're all done moving stuff in, getting set up, and I'm maybe halfway, It's
right.
It's just you have to accept it's going to be a longer process and things, but
yeah, fair enough. I remember the last time I had a major move. It was a fairly big move, 2,500 mile kind of move. And yeah, it was just you don't see the end of the boxes for months, because you do a little bit, some of them go away. The important ones get emptied, and then you got some other stuff.
And you just can't do it all at once. It's just not possible.
Anyone that says I'm going to set aside my Saturday and Sunday and just go through these boxes, yeah, good luck.
Good luck. Yeah, exactly.
But hey, man,
go ahead.
I was just going to say, if I was in your shoes, spending time with the kids trumps the boxes anyway. And honestly, maybe they'll just get excited one day and start just throwing stuff out of the box that you can just catch. And that goes there.
I was trying to involve them with this building yesterday, and it went pretty well for 10 or 15 minutes. And then they started picking up hardware and throwing it around. And I was okay, let's settle down over here,
Yeah. Not time to break down the house quite yet.
I've just been thinking, I just want to provide some encouragement to the people who are out there, life on the line, studying for the MCAT right now. Because I just started this new program, and I've just been thinking a lot, because it's you start over so many times in medicine, in medical training, right? You start over I don't know if I would call it starting over when you start studying for the MCAT, right? It's a new language kind of you have to learn,
fresh, right?
Starting fresh. And then you get to med school, and it's some of the things you've been exposed to before, but a lot of it you haven't. And so you kind of start over in basic science and things. And then when you get to your rotations, every month or two, you start a new rotation, and you have to start over with something that you just don't know about, And I've just been thinking about that this week as I'm starting out with dermatology, and you learn some dermatology in med school, but not that much. And
right,
it's a little bit discouraging, to start kind of not from scratch, but to be starting fresh, like you said. And so I just it is something that you just have to get used to, and it's just part of your life. And, as physicians, we really never stop learning. And I think things become more familiar, in 15 years when I'm a practicing dermatologist and the new papers are coming out, I'll be more familiar with the stuff they're talking about than I was as a first-year medical student starting on day one with, the things you're learning. But the principle is the same, And so I've just been thinking about it a lot. And I just feel for all of you guys who are out there, busting your butts, working really hard and studying, and it is such a process, but it's your life now, it's something you got to get used to, and it gets easier. And so I just wanted to provide that encouragement to our people who are out there and listening, that we're rooting for you guys, and that it's possible, you put in the work and things will work out for you. And I really believe that.
Yeah, well said. And I think even for you, Eric, day to day is, starting fresh to an extent. you're meeting new patients with new backgrounds, right? And so like even within the same general space, there's a lot of turnover.
Yeah.
And on one hand, turnover is exciting because you don't get bored.
You don't
On
get
the other
bored.
hand, turnover is stressful because you're always on your toes and you can
Yeah.
never take anything for granted.
Yeah.
And so, there is a little bit of a dichotomy there, but you're right. Like, there's always a fresh start. And I think you can look at it as a positive or as a negative. And Azai, who many of our listeners will know, was a integral member of like the Jack Westin leadership and
Yeah.
instruction department. She said something in one of her last episodes on this podcast that actually really resonated with me, and explaining why she decided to step away from Jack Westin for the time being. She said that, my whole life, I've always been like just waiting to get to the next step, right?
Yeah.
When I was in high school, I was waiting to get into undergrad, and then I got into undergrad, and then it became, all right, well, now I just need to get into med school.
Yeah.
And then she got into med school, and then she's like, now it's just about getting into residency, or now I just got to find a job, right? And like she says so eloquently, I've lived most of my life just waiting to get to the next step, and I want to start enjoying this step a little bit more. And she said that. I was like, I'm very much the former. I'm not so much the latter yet. It's been a work in progress for sure, but if Azai ever hears this, that was really empowering advice. But I think that's something that doesn't really change regardless where you are, right? I think even as a parent, right? And granted, I'm not a parent, but like I can reflect on when my sister was just born, and for context, there's about a 12-year age gap between us.
Oh wow, yeah.
And I remember, there's this progression of like, all right, like we just got to get to the 2-year mark where we're not worried that dropping her is going to cause any sort of trouble.
Yeah.
And then we get to like the 4-year mark where crawling isn't so much of a threat anymore. And then you get to the 6-year mark where you can start to have like legitimate conversation. Like, you're always just like counting down to the next milestone.
Yeah.
And I think, the old cliche of, it's not the destination, it's the journey, right? I smile and laugh whenever anyone says that, but it does hold, a good amount of meaning. But in a logical transition, let's start talking about the heart.
Yeah.
I'm sure there's a relationship there, but in any case, I think what's interesting with the cardiovascular system as a whole, when we think cardiovascular system, we think heart, we think arteries, we think veins, and there's actually a lot more to it. There's also the lymphatic aspect of circulation, and there's also the digestive aspect as well in terms of delivering nutrients. So we think of the circulatory and cardiovascular system as being, delivering oxygen and delivering carbon dioxide to the lungs. I think it's important as we dive into this conversation to understand that there is more to it than just that. And there's different things that affect the cardiovascular system, but we'll get into that as we go. I think a logical place to start is the heart. And, as the starting point for, the movement of blood. And so, if we start at the right atria, right, where do we go? Right. And then I think importantly, like, why do we go there?
Yeah. It's interesting. And it's interesting to hear you talk about it. I feel like we like to dissect the cardiac and the pulmonary systems out a little bit, but like when you're thinking about what they do, it really does become like cardiopulmonary physiology. You can't really take one without the other. And we won't really get into the lungs today, as you said, but I think it's important to recognize there is such a real kind of like integral interplay between those two systems.
Right.
When I think about like starting with the right atrium, I might get myself into a sticky situation here, but I can't talk about the right atrium without saying where the blood is coming from into the right atrium. And so like before right atrium, we have veins, right? We have superior vena cava and inferior vena cava, and those are like the two big veins that are gathering all the blood. Superior from the head and the right side of the body, the right upper arm, I should say, and left upper arm, and then inferior vena cava from everything kind of below the heart. And all of that blood is being dumped into the right atrium, right? And all the blood at that point is deoxygenated, right? And so one important thing to note as you're thinking about the heart on the MCAT is that the blood on the right side of the heart is deoxygenated. And where does it go? I'll get into the nitty-gritty of the right heart in a moment, but ultimately the purpose of the right heart is to receive blood from the body that's deoxygenated and to get that blood to a place where it can get oxygenated. Because ultimately, if our blood isn't oxygenated, then it won't be able to carry the nutrients and things that it needs. And, obviously the oxygen
Right.
the tissues in our body need to be able to perform their appropriate functions. So, you get deoxygenated blood dumping into the right atrium, and then that blood will pass through the tricuspid valve into the right ventricle. So atria are kind of receiving blood, and ventricles will be pumping blood out of the heart. So you have deoxygenated blood comes into the right atrium, passes through the tricuspid valve and into the right ventricle, and then the right ventricle will pump that deoxygenated blood through the pulmonary valve and into the pulmonary arteries. And this is a really important point as well. When we think about arteries and veins, usually when we're thinking about these vessels, we're thinking about kind of the systemic circulation. So everything other than circulation to and from the lungs. And so when I'm talking about an artery in the leg, the femoral artery, it's taking blood away from the heart. And that's how we define arteries and veins. It's not based on whether the blood is oxygenated or deoxygenated. It's based on whether it's taking blood away from the heart or bringing blood back to the heart. Okay, so any artery that we talk about is taking blood away from the heart, whether that blood is deoxygenated or oxygenated. And then any blood that is bringing blood back to the heart is, or any vessel that's bringing blood back to the heart, is a vein, whether that's oxygenated or deoxygenated blood. So the pulmonary arteries, Ahmed, will you tell us, if we're talking about pulmonary arteries, it's taking blood away from the heart, and tell us about that blood. What kind of blood is it? Is it oxygenated? Is it deoxygenated? Where is it going? And what is it going to do when it gets there?
And so on that note, we know that blood is coming from the right ventricle, as you mentioned, and we mentioned before that it's coming back from the body to the heart and it's deoxygenated. I think it's important to just explicitly acknowledge why, right? It's easy to take that for granted, but it helps to just reason why, right? Like, where did that oxygen go? Well, it's as simple as our tissues use that oxygen in the electron transport chain to make energy, right? So our body has actually consumed that oxygen, right, and turned it into water. And so that's why, leaving the lungs and coming back to the lungs, there's a marked decrease in the amount of oxygen in the blood. And so it's gone to the tissues. That oxygen has turned into water in the electron transport chain. Now our blood cells are coming back to the right atrium through those vena cavae in a deoxygenated state. And then we enter that pulmonary artery, which is going away from the heart, and pulmonary tells us to the lungs, where now we can exchange gases. Carbon dioxide has a pressure gradient into the lungs. Oxygen has a pressure gradient into the blood vessel. And now hemoglobin picks up that oxygen. And so now we've gained more oxygen, right? That's why we breathe, is to bring in oxygen that allows us to create usable energy from the food that we eat. And so now that we've picked up that oxygen, we bring it back to the heart. If it's coming back to the heart, we know it's a vein, in this case, the pulmonary vein. And now we enter, the second side of the heart. And, I was always taught that you want to think of the heart as a two-pump, synchronized system, right? Because both sides of the heart are pumping to different, destinations, we'll say. The right side to the pulmonary circulation, the left side to the rest of the body. But what's important to understand is they're pumping the same amount of blood.
Yeah.
They're pumping with different
system, right?
Right. Because if we pump different amounts of blood, now blood pools, and obviously there's, microscopic fluctuations beat to beat, but on average, right, we're pumping the same amount of blood. Otherwise, blood pools in one sort of leg, not literal leg, one area of the system, right?
Often the legs.
Yeah.
So it turns out, but okay.
One part of the system. But they have different pressures, obviously, because the right heart is pumping just to the lungs, which are nearby. Left heart obviously needs to be a lot thicker, more muscular to generate more pressure, since we're pumping to the big toe and the forehead and, everywhere in between. But yeah, so now we're back into the left heart through the pulmonary vein, entering the left the left atrium, then through the mitral or bicuspid valve into the left ventricle, which, as we just kind of mentioned, is really thick and muscular, and that will contract to pump blood through the aorta, which can now go to all the different tissues in the body to deliver, oxygen and create usable energy. In terms of heart anatomy, that's, as far as the MCAT goes, all we really need to know. We touched on the different valves, the arteries, and the ventricles. But while we're on the note of contraction, I think it is important that we also understand how contraction of the heart works. And so this is another thing that I see students confuse a lot if they're not paying attention, is they'll confuse cardiomyocyte action potential versus a pacemaker potential. And it's important to understand, again, the why behind those things. And so I think it may be worthwhile to just briefly go through what contraction of the heart looks like and how that manifests between different cell types in the form of, an action potential.
Yeah. Well, let me walk through kind of the electrical conduction, and then Ahmed, if you'll tell us afterwards about kind of the cardiac action potential and how that takes place and why it's different. The action potential of the cardiac myocyte is interesting, or I should say the pacemaker cells, right? Because there's a difference between, your kind of run-of-the-mill cardiac myocyte, which has, gap junctions that can transfer this electrical impulse along the heart very quickly, which is how the heart is kind of contracting all at once. But the specialized cells that are causing the action potential are found in the sinoatrial node. And so that's kind of where our electrical conduction system in the heart happens. Like sinoatrial, I guess I'm trying to think of what sino is referring to. I think it's like maybe some sort of sinus that exists in the heart. I don't know what the anatomy would be, but the sinoatrial node kind of exists between the atria. And it's, this little center of impulse-inducing cells. And so they start an action potential, and it will travel along from the sinoatrial node to the atrioventricular node. And so if you think about, cardiac anatomy, the atria kind of sit at the top of the heart, for lack of a better word, I guess the superior aspect of the heart as it sits in the body, you could say. And that action potential moves inferiorly or down, I guess. I don't know how. It's kind of interesting because the heart sits at like kind of a weird angle in the chest, but moves down towards the atrioventricular node, which is, again, a kind of a ball of cells that sits a little bit in between the atria and the ventricles. And at the atrioventricular node, there's kind of a pause in that action potential, and it kind of holds it up for a moment before kind of disseminating it through the rest of the heart. And that's important because it allows us to have an offset between the contraction of the atria and the contraction of the ventricles, right? So we don't want all of these chambers pumping at the same time, because you would effectively have, if you had atria contracting, pushing blood into the ventricles, you'd have ventricle contracting and pushing blood back into the atria. And so you have the atria that contract first and kind of squeeze that extra blood down into the ventricles. And then the ventricles, after, a split second, will pump. The tricuspid or bicuspid valve will close, depending on what side of the heart we're talking about. And then the blood from the ventricle will exit the heart and move along to wherever it needs to go. And so there needs to be a pause. And that's what occurs at the atrioventricular node. And after conduction through the atrioventricular node, it moves through the bundle of His, which is, again, kind of a conduction channel that runs in between the two ventricles of the heart, the right and left ventricles. and then those fibers will run kind of around the outside of the ventricles of the heart and allow it to contract all at once. Again, there are, we're not talking really about cellular, intercellular connections in this episode, but the reason that those action potentials are conducted so quickly and that everything can contract all at once is because there are gap junctions in those cardiac myocytes that allow, the ion transitions that are causing the action potential to occur kind of all at once, all across the heart. And that allows us to have kind of a coordinated contraction. So it's kind of it's a beautiful physiology. But Ahmed, tell us about, I remember like there are funny channels that exist in the cardiac myocyte. I don't know if we'll get into that, but there is this kind of autonomous action potential inducing mechanism in these cells that doesn't exist anywhere else in the body that allows us to have this continuous heartbeat without having to think. Can you tell us more about that?
Yeah, so it's funny because the sinoatrial node and the atrioventricular node both have what we call myogenic activity, which is basically they can induce an action potential independent of the nervous system.
Yeah.
And the difference, though, is that the sinoatrial node has a higher frequency, meaning a higher baseline heart rate. And so somebody with a faulty SA node can still innervate the heart through the AV node. They would just need a lot more sympathetic stimulation at baseline to elevate the heart rate a little bit, but beyond the scope of the MCAT. Basically what happens is, like you mentioned, we've got these, they're literally called funny channels. Not sure why, but they're these.
I guess. I don't know.
Yeah. Anyway, there's these sodium channels that basically allow the influx of sodium up to a certain threshold that then leads to our typical action potential. And this happens very regularly. And so this is independent of a ligand or independent of anything else. This is specific to these pacemaker cells. Whereas in contrast, the myocytes, the muscle, right, we need to make sure that muscle has enough time to relax after each contraction so that we get maximal ejection of blood from the heart. Otherwise, we risk an incomplete contraction where now we're not ejecting as much blood from the heart. We're not delivering as much oxygen. We're allowing blood to pool in certain areas. And that can have obviously some very serious consequences. And so to ensure that the heart is contracting with maximal contraction each time, we need to lengthen what's known as the refractory period, which is basically the period in which, you either can't, well, the simplest explanation is the refractory period is a period of time where you can't generate a normal action potential. Within that are two subcategories. There's the absolute refractory period where you can't generate an action potential at all. And there's a relative refractory period where you need a suprathreshold stimulus to elicit an action potential. And so what ends up happening in these cardiac myocytes is we have these calcium channels that open at the peak of the action potential that allow an influx of calcium. This, for a little while, offsets the efflux of calcium, which is trying to repolarize the cell. So we end up getting this long plateau phase. In doing that, we allow for the refractory period to lengthen a little bit to allow the muscle to relax. And now by the time that action potential is completely done, because it's longer, we've now overcome the refractory period and now can contract again with a higher or with the same level of force to make sure that blood is being delivered adequately. But it's interesting, the heart is very autonomous. It can be modified, obviously, through the central nervous system, but there's a lot more detail than what we're getting into today. But it's always interesting to think about, your heart is just controlling when it's beating, right? It's just it's its own boss,
just doing it.
Yeah. But obviously a very, very important part of our physiology. But I would encourage anyone who's interested in this stuff, just like do some independent reading, not necessarily to study for the MCAT per se, but like there's a lot of intricacies that are quite, fun to learn about when it comes to the heart and its autonomic activity. But in any case, as far as the MCAT is concerned, that's really the bulk of the heart between, the electrical conduction pathway, and the structures of the heart. One thing that I will add, sort of building off what you said there earlier, Eric, is that this conduction goes down and then back up, which basically initiates contraction from the bottom up of the heart.
Squeeze it out, squeeze the blood out like that. Yeah.
Exactly. I always think about it like you're emptying a tube of toothpaste, right? You just move your fingers from the bottom up, right, to make sure that everything's coming out, right? Because if we contract from the middle, some goes up, some goes down. It's not as efficient of a process.
Yep.
And so I guess, this really does just speak to, again, like knowing the why behind the what. Like we could know that, okay, yeah, the heart contracts from the bottom up. Knowing why that is important, and it's to make sure that all that blood is injected and going where it needs to go.
Yep.
We talked about the pulmonary circulation, though. Now as the blood leaves the systemic circulation, or leaves the left side of the heart and enters the systemic circulation, where is it going and why?
Yeah. So important to note that like pulmonary, I think you made a really important point earlier on, which is that you have to kind of divide the circulatory system into two different sets of things. There's pulmonary circulation and there's systemic circulation. When you take the MCAT, you may well see, terminology surrounding. Sometimes they'll throw in questions about pulmonary circulation to throw you off. And again, I'll just reemphasize that that's because when we talk about an artery, usually we're thinking about oxygenated blood moving away from the heart to provide, oxygen and nutrients to tissues. When we talk about the pulmonary system, it's the opposite, that the pulmonary artery is taking deoxygenated blood to the lungs to receive oxygen and get rid of carbon dioxide, to breathe off carbon dioxide. And then the pulmonary arteries, the pulmonary veins are bringing back oxygenated blood. And so it's really important. Like if you're not getting what I'm saying, like go look it up, go look at a picture, because they'll color everything red and blue. It makes it easier to like kind of conceptualize. But that's really important. Like if you mess those things up, it's easy to get question wrong. Now, the whole point of this system is to be able to, as Ahmed said, get oxygen to our tissues so that they can participate in cellular respiration. That oxygen will go to the electron transport chain and it will allow us to produce ATP so that our cells can do the things they need to do. And so oxygenated blood is going everywhere, right? The blood vessel that comes out of the left ventricle, is called the aorta. And the aorta is like the main I'm going to say main artery. I was thinking like main highway, but like in big cities, they'll call, the big roads arteries. So, this is like the main artery by which all the blood in the body goes everywhere that it needs to go from the heart. I don't think we need to get into like vascular anatomy. I think that's beyond the scope of the MCAT, but ultimately like you have some big branches that go up into the upper extremities and into the head especially. And then you have like a big branch of the aorta, the descending aorta it's called, that kind of runs along next to the spine and provides blood to like all of your internal organs. And then obviously there are like femoral arteries that run down into the legs and end up providing blood to those areas there. I think it's important to recognize like what the vessels are called as we move along the circulatory system. I had an interesting conversation the other day. We did like a cadaver lab as we're like starting residency, and we went in and like looked at like head and neck anatomy, because for some of the procedures that we do on the head and neck, we need to know like the vasculature and where things are to try to avoid big vessels and things like that. And the more senior residents were talking about like some boards type of questions, like buzzword MCAT sort of things, except for the next step down the road. And they were saying, there's this artery, I can't even remember what it was called because I'm so like it just went in one ear and out the other for me. But they were talking about an artery that kind of comes up along here and like comes up along the nose, and they were saying like, oh yeah, it has one name here, it's called something else here and something else here. So if you think about like the femoral artery, for example, When it's in the thigh, it's called the femoral artery. And then when it gets down behind the knee, it's called the popliteal artery. And then when it gets
Right.
down further, it gets into the foot, it's called dorsalis pedis. And like, it just has these different names depending on where it is. So it's kind of
Right.
interesting that like all the blood vessels in the body, like you could think of them as like one big blood vessel. Like it all connects. You know what I mean? Like there's no point at which like you have an aorta and it turns into the femoral arteries just because we decided that that's what it's called. So it's kind of interesting that we make these distinctions, but it's, to help us visualize the anatomy and know where things are. But the big vessel coming out of the left ventricle is the aorta. And then we have what we call, large arteries, but arteries ultimately is what we're calling like these bigger blood vessels that are taking blood away from the heart. And as they kind of narrow down as they get closer to their target tissues, then they're called arterioles. And those are these kind of smaller arteries that are getting to the point where they like don't have names at that point, right? Like the femoral artery is a big artery; it's named, we know where it is. At a certain point, they get small and narrow enough that we're not giving them specific names anymore. And so those are arterioles, and those arterioles get smaller and smaller until they anastomose or connect with a venule, which is the smallest kind of vein. And in between those arterioles and venules, then you have kind of a capillary bed. And those are like the smallest blood vessels that we have. We talked about pulmonary circulation, like when you have blood vessels that are doing gas exchange in the lungs, those are capillaries. Like they're so small that you only have room for like one little red blood cell at a time to kind of march through those capillaries. So they get really, really, really small. Once they go through kind of the capillary bed, then they come out the other side deoxygenated, right? Because the capillary bed is where gas exchange is occurring.
Yeah.
They enter into venules, and from venules they move to veins, which are larger. So on the arterial side, the systemic arterial side, we're getting smaller and smaller and smaller as we get to those target tissues. And the opposite occurs on the venous side, which is that you start with venules and you move to veins, and then ultimately it kind of coalesce or come together into the vena cava, right? And that's where all this deoxygenated blood is coming into and dumping back into the heart. And on the venous side, these red blood cells, it's kind of funny, like after one pass through the circulatory system, they still have a lot of oxygen. Like you can still survive off of how much oxygen you have after one pass. Like it takes a few passes to really deplete the oxygen to the point where you're in trouble.
Right.
But you are getting some deoxygenation in the tissues. And then as you alluded to earlier as well, Ahmed, you have gas exchange, you're picking up carbon dioxide into those red blood cells and into the deoxygenated blood, and then you're picking up other waste products that will ultimately go, to the liver, and then in the systemic circulation can go to the kidney as well for more filtration. And so you have kind of not only gas exchange, but you have like nutrient delivery and byproduct and waste delivery out of those tissues. And that's part of what all of these blood vessels are doing. Can you tell us about like differences between arteries and veins as far as the anatomy of the artery and the vein itself? Like what do they look like? How are they different, and why are they different?
Yeah, I mean, I think it speaks to the importance of knowing the difference between the blood vessels in general, like which ones are very elastic, which ones have lots of fibrous tissue, which ones are very muscular, right? I think, again, knowing what things do will help you understand where they belong, right? So let's start with fibrous tissue. Very thick structural integrity, withstands high pressures, right? Or high blood volumes. Aorta, arteries, vena cava, right? Loaded, right? Mainly the aorta and the vena cava, right? It makes sense that they're going to have a lot of fibrous tissue because they're holding the most blood, right? So they need to be very structurally. What's the adjective of integrity? Very structurally.
I don't know.
Very structurally
sound. Yeah.
Yeah, exactly.
Yeah.
I was gonna say something. I was like, wait, that's not a word.
Yeah.
I was gonna say integral. I was like, no, that's not it. Anyway, so that makes sense there for fibrous tissue. Let's think muscle. Muscle contracts. So we're thinking regulation of blood vessel diameter to regulate blood flow. That's got to be our arteries and our arterioles, right?
Yeah.
Lots of muscle, right? Then we think about elastic tissue, the ability to recoil. This has to be in our aorta in a high amount, as well as some of these other delivery vessels. The aorta especially, this is important to understand, like blood flow doesn't just stop in between heartbeats, right? Otherwise, you would see a very square shaped curve in terms of oxygen delivery. But really it's heartbeats and then it's a nice slow plateau. And then heartbeats again, it's a slow plateau. Right. And the reason for that is because there's this elastic recoil of the aorta, which kind of squeezes the aorta and moves blood, more distally, we'll say, from the heart. And so in terms of arteries and veins, arteries are more the delivery vessels, whereas veins are more collection vessels. Structurally, veins have valves, right, to prevent backflow of blood, which is important because they're lower pressure systems. And I think, if we think of pressure as a wave of energy, this makes sense. Veins are further from the heart, so the wave is dissipated a little bit, right? So there's less pressure. Veins also have a high, what we call compliance, right? And so, like I mentioned, there are these collection vessels. Compliance basically just means at a given pressure, they can expand by a certain volume or hold a certain volume of blood. So their compliance is essentially synonymous with stretchy, we'll say. But I think, again, it comes down to understanding what the function of these vessels are and then what structural components make sense, right? So if arterioles are meant to regulate and fine-tune blood flow to certain areas, they need muscle, right?
Yeah.
If the aorta and the vena cava are going to hold tons of blood, they need a lot of fibrous tissue to be structurally sound, right? If the aorta is responsible for sort of continuing to some extent blood flow in between heartbeats, it needs elastic tissue to do that.
Yeah.
And I think framing, structure in the context of function is a recurrent theme, beyond cardiovascular system, but another case in point.
Absolutely. Yeah, it's interesting. But part of that, like muscularity of the arteries as well, is because there's so much pressure. We haven't really talked about this too much. I want to touch on it a little bit. There's so much pressure in the systemic arterial system, in the systemic delivery of blood, right? You have the left ventricle, which is highly pressurized, and it's like really squeezing, really forcing blood out at a high, at high volumes. And because of that, you have a lot of force acting on those arteries, and so they need that muscularity so that they can withstand the force, right? If we had the volume and flow of blood flowing from out of kind of the left ventricle, like if you replaced your aorta with a vein, the vein would just like blast open because it's just it doesn't have the structural integrity like you're talking about to be able to withstand that kind of force. And it's interesting, I feel like I've maybe talked about this on this podcast before, but like at a certain point in your training, Ahmed, you will need to do a central line, or at least you'll like be in the room when someone's doing a central line. And what? Can't wait.
Can't wait.
And they used to do it. I don't know if you've ever read any books by I'm trying to remember his name. He's like the chief of health for Amazon. Do you know what I'm talking about? He's written some books. Anyway, it doesn't matter. But he talks about like he trained at Harvard, like, I don't know, 20 or 30 years ago. And when they did central lines, like they would put them in kind of in this subclavicular area, and they would do them blind, like based on the knowledge of the coursing of the artery that we have, like, or the vein really, because a central line goes to vein. But they would be like, here are the landmarks that we have. And so like, we're going to put the needle in right here at this angle and like go until we find what we're looking for. But today we put them, often you can put them subclavicularly as well, but a lot of times we'll put them in the neck, and we'll use an ultrasound probe. And so you're kind of like visualizing what you're doing, and you can guide the needle with the ultrasound probe to not hit anything you're not supposed to hit, right? And whenever you do this sort of a procedure, like you look with the ultrasound probe, you put it on the neck, and you're looking at the carotid artery, and you're looking at the jugular vein, and you want to put it in the jugular vein. because it's a central line. It goes into a vein. Like that's the whole point. And so when you look on the screen, like you'll do the ultrasound and it will show you the vessels on the screen. And when you look at the carotid artery, it's like, it's kind of tight. It's a little bit smaller. It's thicker. And you can see it pulsating because it's getting so much force from the aorta, from the left ventricle. And you can see that thickness on the ultrasound screen. Whereas if you look at the vena cava, it's like, big, or excuse me, not vena cava, but jugular vein. It's this like big kind of floppy vein. And it has like, you know, the wall is very thin and it gets dilated when it fills with blood, right? So much so that if you press down, if you apply some perpendicular force to the neck, the artery like will barely move. Like it will just sit there and pulsate because it's delivering oxygen to the brain and like it needs to stay open. It has that muscularity. Whereas the vena cava, like it's big like this. If you apply some pressure, it will just like fold close because it just doesn't have any of that structure. What's also interesting is when we talk about like the oxygen transfer into the tissues and like the movement of substances in and out of the capillaries. So I wanted to talk a little bit about like hydrostatic and osmotic pressure in the capillary. This is a little bit of a shift. Do you have anything else you want to add before I move on to this?
Honestly, the biggest thing is just understanding that the cardiovascular system moves more than just oxygen. It obviously moves nutrients to different tissues as well, right? We're moving glucose, we're moving fats, right? We're moving proteins. So it is just a bulk transport system. That transport, obviously, most importantly, includes oxygen, but it includes other factors as well. But I think it is important, as you mentioned there, to discuss how do things move into and out of those vessels.
Well, I just got thinking about it because we're talking about pressure, right? And the way that fluid moves. So like when you have arteries that are anastomosing with veins, again, anastomosis is like the connection. It's like a connection of one vessel to another, right?
Yeah.
So you have kind of arterioles that anastomose into capillaries, that anastomose into venules. And when we're talking about what happens at these capillary beds where we have transfer of nutrients, it has to do in part with the pressure that exists in this kind of system. The arterial system, the arterial side of the cardiovascular system has a higher amount of pressure because it's receiving a lot of blood from the left ventricle. And so it's kind of squeezing and pushing out. It has a lot of hydrostatic pressure, I should say. When it gets to those capillaries, it will like force those red blood cells through the capillaries and some fluid with it. But some of the fluid, because the hydrostatic pressure is so high in the arterioles, some of the fluid will be kind of forced out of the vascular, of the lumen of these vessels and kind of go and sit in the extravascular space. And so we have, you know, hydrostatic pressure that's pushing fluid out into the tissues. And so, you know, if that were the only force that were acting at these blood vessels, then you would just develop a bunch of edema. Like you'd have all this swelling in your tissues and you'd never be able to get any fluid out, right? And so somehow there has to be a mechanism to be able to pull fluid back in to the veins so that you don't have, you know, stasis and edema and just fluid that just sits there and never gets out. And, you know, sometimes in patients that have bad edema, what we'll do is we'll just give them compression stockings and we'll say, you know, use these compression stockings. They'll provide some counter pressure to try to force that fluid back into your vascular system. But the way that the body counteracts this is that the fluid that remains in these vessels, so you have fluid that is pushed along through the capillaries and into the venules. By the point it gets to these venules, it's super concentrated, right? Because you've lost a bunch of fluid that was pushed out into the extravascular space. And so the fluid that remains is just chock full of solutes, right? And so it has a higher osmotic pressure because of that. And because of that higher osmotic pressure, it will draw in some of that fluid that's in the tissues back into the vascular space. And that will kind of reconstitute some of the blood volume that was lost by pushing it out into the tissues. And then that volume and those blood cells and everything will go back up through the veins. You know, I think this is maybe a conversation for another day. I just wanted to bring it up because these are the kind of connections that you need to make, you know, like they will certainly, this is definitely fair game for things that they could be asking you. You know, we're talking about chem phys concepts with these different types of pressure. But in the context of this biological system, it's certainly something that it pays. It would be advisable to be familiar with, because something like this could come up.
Yeah, no, I think that's well said. And it's important, like you said, to be able to understand how structures and functions are integrally related. And with respect to blood flow in and out, right, that's why we have, these, not just why, but one of the reasons why we have these proteins in our blood, right? They're solutes that create an oncotic pressure, oncotic being a type of osmotic that's specifically due to proteins, right? That helps move fluid in. We have a large hydrostatic pressure, though, that allows fluid, a net fluid, expulsion, or a net fluid exit from the vessel, right? And then we get on the other end of the capillary bed, where now we want those veins to be collection vessels. So it makes sense for the osmotic pressure to exceed the hydrostatic. And in the capillary bed, we want them to be equal so that we don't get fluid thickening the alveolar lining, but we also don't want to, suck in the surfactant from the lungs and then our lungs collapse, right? So it's wild how intricate and delicate these systems are, but
it's a delicate balance. Yeah.
That's a story for another day. In terms of the cardiovascular system, that's the vast majority of it. To note, I think, as well as just the lymphatic system. Lymphatic system, as it pertains to the cardiovascular system, main application here is that we're collecting fats, right, from the digestive tract. So thinking fat-soluble vitamins and fats in general, they enter the lymphatic system and then re-enter the bloodstream, I believe, in the left subclavian vein.
That sounds good. Yeah.
Feel free to, for our listeners, feel free to double check that, but not something MCAT testable. Just understand it re-enters the bloodstream in the upper area of the cardiovascular system. And the MCAT won't test in deeper detail than that. But yeah, like I said, I think that's the bulk of the cardiovascular system. If we take anything from today, understand again, structure and function are integrally related. Know the whys behind the what, and like Eric mentioned there, make connections as much as appropriately possible. If that makes sense.
Yeah.
Anything to add there, Eric?
Yeah, no, that's great. Great summary on that. I guess I would just add, and you said this before too, like do some reading on the heart. There's a lot to study for the MCAT. So, if you're just swamped with MCAT stuff, that's great. But if you find the heart interesting, it's such a big part of medicine. It's a big part of your preclinical years. It's a big part of the medicine rotations you'll do, and even the non-medicine rotations. And so if there's something that you were going to study, the heart is a good place to start. It just plays such an important role. And really part of it is that there's so much cardiovascular disease in developed countries that it's something that you'll see probably more of than anything else is cardiovascular disease. So it never hurts to be more than prepared on some of these topics.
Definitely. But yeah, I think, I think that speaks to another important point. Like if we can learn to learn, not learn because we need to, it's going to be a little bit more fun, a little bit more sustainable. Yeah. And I hope for all of our viewers and listeners that they're able to incorporate that into their practice and make MCAT prep as enjoyable as it can be. But to those viewers, of course, we wish you all the best with your prep. We thank you again for listening to this episode of the Jack Westin MCAT podcast, and we'll see you on the next episode. Happy studying. All the best, guys.
Happy studying.